Yeah, I think I'll go ahead and start. Thank you for coming out in the cold and rain to attend Grand Rounds today. So my name is Dr. Milligan, and I'm going to be giving you an update on our lung cancer screening program, some basics about screening, and about lung cancer screening in general, and also a little information about our program here at LSU. I don't have any conflicts or disclosures. Now, if you'd like to know more, I think this is on your CME sheet. There's a nice review from one of the pulmonary journals in April. And also there's kind of a classic article in Radiographics from 2015. It really also helps with the radiology of lung cancer screening. Now, I'll start with this slide. And that's because we're a certified lung cancer screening center. In fact, we're the only one in Northwest Louisiana. And as I was preparing this, I thought that I just wanted to highlight it because at our medical center, we have certain things that we offer that are unique. And no other hospitals around offer that, and that's something to be proud of and to advertise and publicize. And that's not surprising given that we are a medical center, a medical school. And this is one of those, and I wasn't sure that other people knew that. Other hospitals may do screening and lung cancer screening CAT scans, but we're the only one that's really a certified center. And as I go along, you'll know a little bit more about what that actually means. Now, obviously, this is a way to try to decrease the risk of cancer and increase the cure rate of cancer. So this is a little bit of a background. How might we think about doing that? Typically, we think of treating cancer when it's already diagnosed, but it's really much better if we can prevent it or detect it early. So a couple of examples of that would be HPV vaccine in preventing cervical cancer. That's really been a tremendous advance. And similarly for lung cancer, smoking cessation is really important because most lung cancers are caused by cigarette smoking. You're familiar with pap smears to detect precancerous cervical lesions, or colonoscopy to look for polyps. If you can remove polyps, and most colon cancers come from those polyps. And then there's the category of early detection. So mammography is one, PSA testing is one, and CT screening is another, which we'll talk about today. But within the CT screening program, we're actually employing two of these. It's a CT screening, but also, as you'll see, smoking cessation has a really critical role. So we're employing two methods, actually, to try to decrease the risk of lung cancer death. Now, just another general point about screening. We have all these methods we've alluded to for screening, mammography, PSA testing, CAT scanning, etc. But does screening always work? Which cancers does it help? Can you screen effectively for all cancers? Well, not necessarily. Screening is beneficial when your test is detecting a cancer that progresses slowly enough that you can find it from one interval to another, whether it be a 1 year, 5 year, or whatever that screening test, however it's employed. And then if you can do something that's going to help to cure that cancer, that's also essential. But screening isn't as helpful if you have a very aggressive cancer. For example, if you're screening once a year, but your cancer is very aggressive and appears within 6 months, and it can even lead to death, for example, a small cell carcinoma, then screening is not going to be very effective for that. So those are known as interval cancers. On the other end of the spectrum, if the cancer is extremely slow growing, and we'll illustrate that, then the screening really may not help you much, and that would subject you to overdiagnosis bias. So just to kind of put that in another context, if we can remove a precursor lesion early, then we can improve survival. And what we're trying to do is improve cancer-specific survival. So again, a colon polyp or a early lesion of neoplasia in cervix, for example, would be examples of that. The problem is, if some cancers are very indolent, it really may not be as helpful to diagnose or even treat those. And in fact, if we try to be too aggressive with that, we may actually even cause more harm than good in treating some of these indolent cancers. So I'm just going to spend a couple of minutes talking about types of bias in cancer screening, so you'll know how this plays out. So one type of bias, and this goes for any type of screening really, and here we're talking about cancer screening. It's not specific for lung cancer screening. But lead time bias is illustrated in this figure. So suppose a patient developed colon cancer, for example, and they presented with abdominal pain and some bleeding, and they lived a few years until they were 60 years old and died at age 60. Okay. Now, if we employed some type of screening, maybe hemoccult testing or something, then we might find that cancer earlier, and we see that they lived this length of time, and we just tell ourselves, well, we did a good job with this. But if they still died at age 60, have we really accomplished anything? We found it earlier, but it really didn't prolong their life more than it would have been prolonged without doing anything. But what we're looking for is to be successful with our screening test is to find it early, but also have some kind of treatment that will actually prolong their lives, which is illustrated here. So instead of dying at age 60, they died at age 70. Now, for any one particular patient, you really can't detect this, but with large numbers of patients and epidemiological studies, then you can evaluate the presence of some of these types of bias. Now, two other types, just briefly. Another type is the length bias, and I've alluded to that because I said cancers that are very slow growing are more likely to be detected by the screening test. In other words, you just have a longer time, with your standard intervals of picking it up. Whereas an aggressive cancer may appear between screens, and it's really not beneficial. Now, with these slowly growing types, if you have extreme examples of that, maybe they're not even going to ever harm the patient, and that's when we call it overdiagnosis bias. So this figure illustrates that. So we'll just say these are the screening intervals. Maybe these are 1-year intervals here, these vertical lines. And here's when we start screening. So in this patient, they're screened, they didn't have the cancer, and before the next year, the cancer develops, it causes symptoms, and it actually causes death before we could actually screen for it again. So small cell cancer or maybe melanoma might be examples of such a rapid cancer. In contrast, the other two lines here in the middle, these are ones where screening would help. So here the cancer wasn't there, but by the next year, before that comes around, you've screened, and you can find the cancer before it's causing symptoms and certainly before it's causing death. So this is where a screen would really be helpful. And this cancer here also would be helpful. You can actually screen for it here. Here they develop symptoms. Maybe they ignored their symptoms, which sometimes our patients do, but you catch it again before it causes death, so you have a chance to intervene and do something about it. And then on the other spectrum, from the aggressive type are the very indolent ones. A few lung cancers are this way, maybe some prostate cancer, some others. They can be very indolent. So you have several opportunities to find them, but even after several years, maybe the person would never develop any symptoms, much less death. For example, you may be familiar with some studies on prostate cancer, elderly men dying from some other reason. They had an autopsy, there was prostate cancer there. They were 85 years old, and the prostate cancer never caused them any problem at all. Now, certainly that's not the case for all prostate cancers, but that's just an example of this indolent form that can lead to overdiagnosis bias. Now, here's an example of that with lung cancer. This is not the most common lung cancer, but it's a variety, lipidic adenocarcinoma. And you see this little fuzzy ground glass area here, and these are going back 1-year intervals. And you can see it's less distinct, and by the time it gets here, you may not even be able to see it on these slides. But very slow growing, very indolent in this case. And if this was an elderly person, especially with other comorbidities, it might be worth just leaving alone and not doing anything about it. Again, that's really impossible to say for any one particular person, but in epidemiological studies, again, we can become more knowledgeable about that. Now here's a solid tumor. This was actually a squamous cell carcinoma, and this was a small tumor, and here it's grown quite a lot larger in 2.5 years. Now generally we certainly don't want to wait for one to grow from this to this before doing something about it, but in this case, luckily the person didn't have any metastatic disease, and so this would be a tumor that's growing at this type of rate that would really be wise to have performed lung cancer screening to catch this a little bit earlier. Now, Why are we interested in this? Well, you know probably that lung cancer has got a pretty bad reputation, and this is why. It's the #1 cause of cancer death in men and women. For example, it causes more cancer death in women than breast cancer. And it's the second most cause of cancer in men and women. So it's a bad one, even though the rate of smoking has gone down. Still, many people die from this disease each year. In Louisiana, we still have a problem too. This is the incidence rate. We're #7 for men, #24 for women, and the death rate #7 for men and #14 for women. So those are numbers certainly we'd like to improve upon in our state. Now, there's been many attempts at screening for lung cancer in the past, and long ago I had a lecture in which I just spent all the time on this because then there wasn't any successful method, so I spent a lot of time going over this. So suffice it to say, we've been at this for a long time, since the early 80s, trying to find an attempt to have a statistically significant benefit. But only with this trial more recently have we found clear proof that lung cancer screening was helpful. So I'll just give you a few details about this because this is what we base our screening programs on, is the data from this study. So this was a very large study, over 50,000 patients, 33 medical centers. Actually, Oxnard in New Orleans enrolled several hundred patients, our new hospital partner. And they followed them for a number of years. And this was the criteria. They used this age range. It was only for cigarette smoking, and it had to be a minimum of 30-pack years, kind of a moderately heavy smoking history. Or if somebody had stopped smoking, they had to have stopped within 15 years. No active symptoms of lung cancer. It wouldn't be appropriate to screen if they had symptoms of lung cancer. And they had to be healthy enough to have surgery for cure because that's the gold standard for cure. Now, why did they choose 30-pack years and less than 15 years for stopping? So this, from another trial, shows the relationship between pack years and the probability of developing lung cancer. And you can see it's fairly linear. And I think the 30-pack years was fairly arbitrary. I mean, you could have choose 40, 25, but certainly in this range, it's going up. We don't see so many patients with over 100 pack years. Now, what's interesting, though, is smoking duration. So it's relatively flat, but you can see at some point it really starts rising much more rapidly. So it's not linear like this. The duration has an independent effect on risk of lung cancer. This just shows that another way. Suppose the patient had smoked for 25 years, 2 packs, that's 50-pack years, and suppose they were 75 when they were screened and found to have or screened for cancer. Then their risk of lung cancer over 10 years would be about 3%. That's 50-pack years. But if you did it a different way with a different patient, suppose they only smoked 1 pack a day. So you said, well, that's great. They smoked half as much. But they smoked longer, 50 years, and they were screened at age 75. Their risk of cancer would be 11%, almost 4 times as much as the person that had only smoked 25 years. So here again, you can see the concept of duration. So even though maybe the patient hasn't smoked as much, if they've smoked a long time and are older, then they're particularly at high risk and should be encouraged to stop smoking. Now, what about the 15 years since quitting? This is data from different studies, the risk of lung cancer versus the years since quitting going down here. The size of the dots represents the numbers of people in the study. So the screening trial chose 15-pack years, and if we look at that, then we either have like maybe a 75% decrease or 60% decrease, depending on which value there is. So it's really a pretty big decrease as we go down to 15 years, but it's certainly not nearly down to 0. Here at 25 years, we still may have a 20% risk of lung cancer over several years. So again, somewhat arbitrary, but this has been used in other studies. But it's not to say that there's no risk after 15 years. I wanted to emphasize that. Now, the patients in this study, they were mostly at academic medical centers, 90% Caucasian. This is the major age range, 60 to late 60s. about half male and female, and about half had stopped smoking. And we'll illustrate our data from LSU here shortly. This is the benefit of the study. This is detecting cancers, and they detected more with the CAT scan, which is not surprising because it's so much more sensitive. The chest x-ray was the control, CT versus control. And death from lung cancer, the number here is reversed, or the lines, because here we're protecting people. We're finding more cancers, but we're catching them early. So with CT, there were fewer deaths. Now, you might have thought that this might go up and really start to flatten off, but it didn't. So this was a statistically significant difference, but it was broadening here as we went out further, but not quite as much as you might have hoped for. And this was actually the important number, 20% reduction in mortality from lung cancer with CT screening. Again, you might have thought, well, gosh, if it's successful, it must be like 50 or 60%. But this was statistically significant, and it's the first and only time that a study has been shown to be beneficial. So based on this, lung cancer screening has been instituted in our country. Now, as a comparison, I'll just use mammography sometimes because that's another commonly used screening tool. So here's the benefit from mammography. So these were a number of trials, and these were shows the benefit. So at age 70, there was about a 20% benefit reducing cancer mortality. For this age, about a 30%. Here, about a 14% for women that were a little bit younger. And here are the deaths prevented. This is death prevented over 10 years per 10,000 women screened. So even with the most benefit, we're reducing deaths over 10 years, 21 out of 10,000. So the numbers, even for mammography, aren't, huge numbers, but it is significant, and certainly no one wants to say that we shouldn't do this screening for breast cancer. In fact, the values are somewhat similar as they are for lung cancer screening. Now, with any screening, we're going to have some false positives. And in the lung cancer screening over 3 years, almost 40% of the patients had some positive finding. Usually those are just little small nodules. And in fact, 96% of them were felt to be false positives by subsequent CT screening. So the way that these are managed, if there's a small nodule, we do follow up based on size, maybe at 3 months, 6 months, sometimes just 12 months. And so most of those don't require biopsy or invasive workup. And so that's desirable. We don't want to be chasing nodules on 40% of the patients with biopsies and things. We can usually just follow them up with subsequent scans. And that's the way the study was designed and the interpretation. So only about 6% of patients needed some kind of biopsy, 4% surgery, and even those that had biopsies, many of them were benign. Now, how about comparing this with mammography then? Suppose a woman is at age 40 when she starts screening. She's screening once a year. What's the 10-year likelihood of a false positive test? Well, it's 60%, which is pretty high. But again, that's often managed by doing another mammogram in 6 months, maybe doing ultrasound at that time, doing other views, etc. Not all women would need a biopsy. About 7% are recommended to have biopsies, but quite a few false positives, not unlike what we see in lung cancer screening. Now, I mentioned early on about interval cancers that develop between screens. And those are the ones that, where screening really fails. And here's, at the first year, we had 47 stage 4 cancers, but at the next year there were 24, the next year there were 35. 3A cancers, 34, 14, 15. So these cancers continue to appear between screens. It's not like you just get a logical progression of stage 1, stage 2. Some cancers are very aggressive, and by the time it shows up, it's already advanced. So indeed, this is not unexpected, but it's just to let you know that lung cancer screening, even though it's good, it doesn't detect successfully all lung cancers. This further illustrates that fact. It's not a large number, but about 4% of patients screened had what was called a negative screen. In other words, there was just some little opacity or scar or something that was called by the radiologist, but on the next screen they actually had a cancer. These were the cancers that they had. So not a lot, only 44 out of 1,000. These were, again, academic medical centers, good radiologists, but sometimes those little nodules are tricky and, there can be problems occasionally. So this can occur, of course, with any type of screen. This is not unique, but again, just so you know that it's a great test, but it's not a perfect test. Now we mentioned overdiagnosis. The estimates may be 15-20% for lung cancer, some of the more indolent cancers, and for the very indolent cancers, it may be even higher than that. These are just estimates, but not so much different for mammography, where some of the more indolent breast cancers could be 10 to 20% overdiagnosed. Now, when we have a lung cancer program, what do we actually need to do? We have to have eligibility criteria. For this, Medicare and all the agencies, insurance, etc., require an informed decision aid. So patients need to have this reviewed with the provider. It's a little document. There's different ones. We've generated our own here. And that's actually a requirement to be paid by Medicare or insurance. That's unlike many other cancer screens. If you do breast cancer screening, you just say, well, it's time for your annual screening. It's time for your annual pap smear, etc. But not so with lung cancer screening. So we need a method for reporting our findings. Smoking cessation is essential. And we need to track our results. And actually, all the results, since we're a certified center, have to be reported to an agency. We use the American College of Radiology, and that's all patients, not just Medicare patients. So we do this, and radiology works to do this. So quite a bit of work involved. Now, I won't go through this, but you can see different organizations have different criteria. But what we use is the Medicare Criteria, and I think that's what's most commonly used, and I'll talk about that more in a moment. I mentioned about the decision visit, and the reason I talked about some of those things early on, you might say, well, I didn't really care too much about hearing about overdiagnosis bias, but that's actually a required element in the decision visit. So we have to cover this. Usually it takes about 30 minutes or so, but we talk about the pros and cons of screenings, like if you have a biopsy, you may have a problem, the role of false positives, overdiagnosis, need to coming back, you may need a PET scan, what if you have a lot of other illnesses, radiation exposure, as well as smoking cessation. So these are not optional. These are required elements to be discussed and explained to the people. Now, what about trying to explain the risk to patients? We talked about the diversity of lung cancer, some indolent, some aggressive, many kind of in the middle, but still quite fatal if they're not picked up on. And this just illustrates this. So I'll just give you a couple of examples here so you can see the concept of how much help there is and how many screens would need to be done. So this is a typical patient, 62 years old, 1.5 packs a day for 35 years. So if we screen them per 1,000 patients, there would be about 4 people that were saved from a lung cancer death. And you would need to screen about 250 over 6 years to save these 4. Now, instead of an average patient, so suppose we chose the minimal criteria. So the minimum age is 55 years old. The minimum pack years is 30 pack years. So that's this patient. So over 6 years per 1,000 screened, you would only avert less than 1 lung cancer death. And you would have needed to screen 1,200 patients. So a lot of patients screened, a lot of money spent to save about 1 person. Here's someone that's kind of on the other end of the spectrum, more heavy smoking, over 100 pack years, older gentleman. And here, we're really averting many more cancer deaths and not needing to screen many people. So there's quite a range of the benefit, and then obviously the risk from false positives as we do more and more screens. So it would be helpful to have a method to kind of explain the risk in a more patient-specific manner. And there have been some prediction models that have been developed for this. And this is one that incorporates age, ethnic status, presence of COPD, personal history of cancer, family history of lung cancer, the smoking pack years, as well as the duration of smoking. We talked about how the duration is important, if they've quit, etc. And it's a complex formula, but it can be employed in an easy manner with this website, shouldiscreen.com. This is from University of Michigan. And you get not only the number, but you get a nice little graph here with low risk. The red is higher risk. And this is nice for the patient to be able to see and kind of get a concept. Well, 4% doesn't seem like that much, but according to the models, 4% is high risk. So it shows it in the red here. And also, it calculates these results about risk of people that might have a complication or something like that versus the benefits, how many people would be saved from a lung cancer death. So that can be a very useful tool. And there's similar tools for breast cancer screening and probably for other types of screening where you can kind of explain to the patient or what category you're you at low risk for breast cancer, moderate, high risk, etc., and help the person decide if they would really like screening or not. Now, how about the nodules? We find lots of nodules, and there's different criteria for that as well. So, a program has to decide what they're going to do. Many of you may have seen this word Fleshner Society, because when the radiologist reads a typical CAT scan, they see a nodule, they usually don't say follow up in 6 months or 12 months or whatever. They say follow up according to Fleshner Center criteria. And that's because Fleshner Society uses some clinical guidelines, especially smoking history, and the radiologist doesn't know that. So they can't exactly say the time interval. That kind of puts it on you to know the criteria. The Fleshner criteria, however, are based on incidentally detected lung nodules. So, for example, if your patient went to the emergency room for chest pain and they had a CT-PE protocol or diagnostic CAT scan and nodule was detected, then that's the type of person we're talking about. Or maybe they had some cough and a nodule was detected. But there are separate guidelines for lung cancer screening. So if we're screening, we don't use Fleshner guidelines, we use something else. Now this again is similar to other types of cancer screens. For example, mammography is typically read with something called the BI-RAD system. It's a numerical category here, where the higher the number means more suspicious, and a recommendation for something to be done, for example, a biopsy. And there's similar systems for thyroid nodules and other types of nodules. And a system was developed for lung cancer screening too. It's called LungRads. So the radiologist reports this, LungRads number such and such, and when we send our information back to you, we say it's this category number 2, and we'll say per guidelines we're going to arrange follow-up in 12 months. So that's where that's coming from. We get a score from the radiologist and we know what the interval should be. So most nodules, over 90%, are going to be 1 or 2. Those are small nodules. The risk of cancer is very low for the lung cancer screening trials. And so we know it's safe to do that. If it's a little larger, we may follow them up in 6 months. And the ones that are bigger, if we get a 4, then those are the ones we have to take very seriously, because definitely there's an increased risk for cancer, and those we're going to more aggressively evaluate, usually with the PET scan and probably going on toward the biopsy in many cases. So I'll just illustrate this briefly. Here's a solid nodule, and here's the LungRads criteria. 1 would be no nodule, and then these are increasing sizes as we go along. And so we have annual screening versus 6 months, 3 months with the option of PET, and here we're probably going to do PET scan and actual biopsy. The tricky thing is there's 2 ways of looking at this. The first number across here is for nodules when you're screening the first time, because if we see a 6 millimeter nodule, it may have been there 6 months, it may have been there 6 years. We may not know that. But on the subsequent screens, it's called new, and here the category is low. So here, if they had their follow-up and there's a new nodule only 4 millimeters, that's a LungRads 3, okay? And radiologists will often have this posted or available because there's a lot of numbers to remember and a lot of combinations. Now we can also have ground glass nodules and subsolid nodules. and there's different criteria for that. So this is the subsolid nodules, and I won't go through all this, but just to see different numbers for this. And ground glass nodules, the criteria are larger. 20 millimeters is the cutoff, because even if it was a cancer, they're more indolent. But again, one value for first scan and another for follow-up. Now, what about other things? This is for lung cancer screening, but that's not to say we're not going to find other findings as well. So in this series of 17,000 patients, about 25% had other findings. That's not too surprising, because a CAT scan obviously very sensitive, and it's going to show up nearly anything. Now, what was significant? Mostly cardiovascular, about 8%, and that might be, for example, severe coronary calcification or a calcified heart valve or something of that nature. We'll find thyroid nodules and adrenal nodules, etc. The incidence of actual cancer other than lung cancer is fairly low, but certainly it can be found as well. What we do for that is early on we tried to do a lot of these follow-ups ourselves, but we're seeing so many people now we really can't do that. So if we find an abnormality related to a nodule, we're definitely going to follow that and do whatever is necessary. But if we find a thyroid nodule, we're probably going to send an EPIC message back to you and say, I'm going to defer that to you to determine what you think should be done. And then you can decide do you want to get an ultrasound or monitor it serially or et cetera. Here's just a few examples of that. Here's somebody that had a normal scan early on, but 6 months later they came with pneumonia and had big mass, which was actually it's actually cancer. So again, interval cancer developing quickly. Here was a person who had a small effusion early, and 1 year later they had a malignant effusion. Now see, this is tricky because this person on the left, they didn't have any nodules. I'm not showing you all the scans. And so it would have been read as a lung RADS 1 follow-up in 1 year, okay? But they have another finding, and so we always have to pay attention to the other findings. We don't want to just ignore those. So since this was an effusion, we would generally handle that in pulmonary clinic, but that's why sometimes we send other things back to you, adrenal lesion or whatever, to take those other things seriously. Because just because it's lung RADS 1 for the nodule doesn't mean that there might not be potentially another serious finding that needs evaluation. And I think I've read that the lung RADS interpretation may change to comment more on effusions and nodes. Right now it's just nodules. Of course the radiologist comments on this in their text, but they may actually revise their reporting system a little bit. Is that true, Dr. Pervigliano? Have you heard that?
We have to add any other changes. In this case, we will mention that the perfusion is worse.
Yeah.
We can suspect that it's
yeah. So they'll notice that, and we have to respond accordingly. Here's a patient that we had seen for their initial scan. They had emphysema but no nodules. And a year later, they had a very large mass. So we might think, well, that's a small cell cancer, but one of our staff saw this patient and realized they'd had symptoms of pneumonia, been treated for pneumonia at another hospital a couple of weeks before, and on follow-up, this totally resolved, and they didn't require a biopsy. So again, clinical judgment, because 4B would be, PET scan, biopsy, but again, the radiologist doesn't have all the clinical information, so that's why we in clinic, or you, depending on what the situation is, has to really go back and do the basic work of history and physical, et cetera. Here was one that cavitating mass, heavy smoker, looks like squamous cell carcinoma, and it was PET positive, but when it was biopsy, it was actually tuberculosis. So they needed a biopsy, but just because it's a nodule or a mass doesn't mean it's always cancer. They'll have to get the usual workup. And here was another one. This person has a woman with some little ground glass nodules, and these can be caused by a lot of different things, but here they were both biopsied, one by bronchoscopy, one by needle biopsy, both sides, and these were the bronchoalveolar cell carcinomas. So. Now, I won't spend too much time on this, but Dr. Pervigliano was here from radiology. He reads a lot of our scans, and the radiologists have to be quite experienced. There's a minimum number of scans they have to have read. They have to be board certified. They have to keep up their CMEs. They have to work in a certified facility. And we have to monitor the dose, etc. And that's part of the requirement too. So this again goes to the concept of being a multidisciplinary approach to be a certified center. And all the radiologists that read the studies meet these criteria. So let's shift to a bit of another topic related to this. I alluded to smoking before, which is an important part of lung cancer screening. And this is a map from 2014. It shows in the darker colors the states with the highest smoking rates. And we're not the highest in Louisiana, but we're right up there, which is not something necessarily to be proud of. It's certainly improved over the years, but we still have a ways to go. Now, as I said, smoking cessation discussion is really important in trying to get people to stop when we see them for screening. And this is looking at some of the lung cancer screening data and shows, well, how much good does it really do? And these are the odds ratios. And for people that have minor abnormalities or even major abnormalities, smoking cessation discussions really didn't, weren't that successful. Only if you had something suspicious for cancer or very suspicious for cancer did you have a statistically significant chance of getting somebody to stop smoking. And that doesn't mean it's not worth trying, but as I alluded to earlier, most of our patients are going to have in one of these first categories, and believe me, when we see people for follow-up, a lot of them are still smoking despite our best efforts. So we really have a hardcore bunch here, and I guess they did in the screening trial too, because a lot of patients are smoking and continue to smoke. But what would be the benefit if they could stop smoking? First of all, this is the continued harm. And the people who developed lung cancer, the ones that were current smokers, had a higher risk of developing lung cancer versus former. And we talked some about if you stop, the duration shortens, and that may give you some benefit here. And even their all-cause mortality was worse, probably because they developed cardiovascular disease, respiratory failure, etc. But what would be the benefit if they stopped? And the people that didn't even have lung cancer screening, that just had chest x-ray screening, if they had stopped for 7 years, their cancer-specific mortality had improved 20%. Now that was the benefit of the lung cancer screening with CAT scan. So if they just stopped 7 years, that's as good as you can do with the lung cancer screening. That's incredible. And this is even more amazing. If they had stopped for 15 years, and we can screen, up to 15 years, plus they had low-dose screening, then they reduced their mortality from cancer 38%. That's about twice the benefit of the lung cancer screening. So even though we're doing screening, which we should, it's really critical at every opportunity to try to get the people to understand this and know the benefit of stopping smoking. And this data is really, really impressive, I think. Really drives that home. This just shows the benefit of stopping at different ages. This is from another study, over 200,000 patients, published just a few years ago. And this is the survival of somebody age 45 to 54 that had never smoked. And this is their survival if they were current smokers. So you're knocking off several years. But if they stopped at age 45, they could gain 6 years of life. Even at age 55 to 64, if they stopped, we're going to push this back by maybe 4 years overall. So even somebody that's a little bit older, I don't think many people would want to sacrifice 4 years. But if we could just convince them to stop smoking. So it's emphasized that we're screening, but that's not a substitute for smoking cessation. And the Preventive Service Task Force actually says, this is kind of clever, screening with CAT scan should be viewed as an adjunct to tobacco cessation interventions. So they kind of turn it around and say the main focus should actually be on tobacco cessation, and incidentally, we're going to do a CAT scan as well. That's how important they view the discussion about smoking cessation. Actually, the Feist-Weiler is part of a community oncology research program through the NCI. They do a lot of studies, and we're actually part of a study with this group for smoking cessation within our lung cancer screening program. Now, I mentioned the multidisciplinary a few times, interventional pulmonary, and we have Dr. Chapman Holiday here and some of our fellows that really do tremendous. And this is another one of those unique things that we have here at our medical center that's not available anywhere else really in North Louisiana. So again, one of those things that we should emphasize and publicize. Radiology I've mentioned, surgery, oncology, radiation oncology, and primary care, which many of you are. They're really where we get most of the patients, medicine clinic and family practice clinics. So we really appreciate your support. So most of you know that how you put in a referral, we see the patient and the same day they get their scan. We always contact the patient by phone and by letter. And then, as I've alluded to, if they have abnormal findings, we follow that up. And if it's normal, we do the appropriate follow-up in 1 year or et cetera. Now, let me just emphasize a couple of points here. I said that we use really the Medicare criteria, also recommended by the American College of Chest Physicians. Now, people have to be a cigarette smoker. Sometimes we get people that smoke cigars and pipes and other things, and they may have an increased risk of cancer of the lung, but the study is for cigarette smokers only. So if they come and we're trying to get their history, and they have kind of a mixed history, they stopped smoking 15 years ago, but they're smoking a cigar now, that doesn't really count. So it's important we have this, and it's important we get the 30-pack years. If they have 20-pack years, are they at risk for lung cancer? Well, they definitely are. But it's not just any smoker, because there's strict criteria. Again, we have to report this to an agency to maintain our accreditation. Insurance has to approve this for screening. And if we fudge on this and say, well, it's 20, you're a nice guy, I'm going to go ahead anyway, then, we could be accused of, fraud potentially. So we have to be careful about this too. So I'm just pointing this out so also you can think about it carefully and try to make sure they kind of meet the minimum requirement. Well, we'll certainly do this, but sometimes patients, they're a little irritated if they come and say, well, I stopped 20 years ago, and with a simple question, they wouldn't have had to make the appointment and travel to our clinic. One other thing, this really is all on the consult now, so if you pull up a consult, this will all be there. Now this slide just shows some of our numbers here. Since we started the program about 2.5 years ago, we've done 415 new patients, unique patients. In contrast to the screening trial, we're about 50-50 African American Caucasian, which rightly should be because that's our patient population in this area. About 50-50 male female, which is also good. Mostly lower grade lesions, which is what we would expect. But look at this, 72% current smokers, whereas the screening trial is about 50%. And this is our diagnosis of lung cancer so far with the initial and follow-ups, about 0.91%, which is not so much different than what some of the other trials show. Now this is a little disappointing. We've had 2 stage 1, which is great, but half of them have been other stages. Of course, our numbers aren't near 50,000, but that's just what we have so far. But to put that to a perspective, this is a study published this year from a population in Los Angeles that was a little more like ours. It was 80% African American, 80% smoking, current smokers like us. They found a prevalence of lung cancer of 0.7%, and both of those were more advanced stage. So what does that say? Well, it says to me that with much lower numbers and lower confidence, therefore, all places, all sites, all populations may not be exactly like the National Lung Cancer Screening Trial. And that's one reason actually is the agencies are requiring the data from all the programs to be submitted, and I think they're looking at this and they're going to determine, is this really effective down the road? Do we need to refine the criteria? Or certain patients at higher risk or whatever. So as other criteria for cancer screens, I think these will evolve over time, and this may point up to that necessity. Okay, this I just talked about. Now I just have a few more slides here, and this one is the role of good health. In the screening trial, over 90% of the patients were treated with surgery. The Preventive Services Task Force, and that's great. That means they had people that could tolerate surgery, because surgery is the gold standard therapy, even though stereotactic radiation therapy is also excellent. But the Preventive Services Task Force pointed out that people that are pretty ill and also maybe older, screening may not always be appropriate, especially if they have serious comorbid conditions. They may not have as much benefit. This was a study that looked at this, and just for sake of time, I'll just show you a couple of points here. This was a survival of people in a screening trial, and their 5-year survival was 95%. But you look at people that were similar age, 55 to 77, and qualified for Medicare, that was a little bit sicker population. Their 5-year survival was 80%. So not a huge difference, but it was statistically significant. And that just points out the fact that the population in the screening trial may have been a little healthier, which is often the case in studies. It's a little different than the garden variety patients that you might see in your practice. And it just highlights the need for people to evaluate that carefully for death from competing causes and comorbid conditions. Now, how could we do a better job in screening for these types of patients? The screening trial just used a kind of crude measures of 30-pack years, but others are developing some prediction models, and I showed you one of those with the should I screen. And this just looks at that, dividing up, this was from several studies, the risk of lung cancer and the deaths prevented. So people at the higher risk are going to have more cancers prevented than those at the lower risk. And how this might play out is if you try to refine the criteria a little bit, this is how many deaths you prevented with looking at all the patients. But if you just eliminated the ones at the lowest risk, the lowest quintile, then you would still have prevented 99% of the deaths. But also, you would have had to screen less. Instead of 300, you would screen 245, and you would have a lot less false positives, 100% down to 83%. So this is how some of that data might be used to kind of refine the criteria for who should be screened. And I want to, I think I'm almost done, but I just wanted to illustrate a couple of more points. And this is kind of difficult. That's why I'm pointing this out, because we want to get the people who need screening the most, but obviously as people smoke a lot, they're going to develop emphysema, they're going to develop coronary artery disease, they're going to be at risk for kidney disease, stroke, all these other problems as well. So from the American College of Chest Physicians this year, they point out that some of these people that are at higher risk may have more trouble tolerating evaluation, and maybe screening shouldn't be performed. And they point out some of these would be people with COPD, with CO2 retention, class 4 heart failure, advanced liver disease, etc. And that's simply because you may find a lung cancer, but they may die from their liver disease before they would have had much benefit from treating the lung cancer. There's no real way to determine this. I've gone to some meetings and tried to look at the literature, and right now it's really all pretty subjective, and it's really on you to try to choose the appropriate person, and we try to do that too, although we don't have a lot of time to spend evaluating a chart, and really our visit is not to examine the patients at all. We're not getting EKGs and spirometries. It's not a pre-op evaluation. So just give this some thought. We're pretty liberal and try to get as many people as we can. But you usually kind of know these people when you see them. If they're just have a terrible prognosis and not long to live, then they might not be the best candidate for any type of screening, whether it be lung cancer screening or colonoscopy or whatever. But again, that's up to you to decide, and we'll try to help with that too. And this final slide just shows this in a graphic form. We talked about the person who just barely meets criteria, 55 years old and 30-pack years, have a very low lung cancer risk, have to screen a lot of people to avert many lung cancer deaths. So this criteria for the low risk might have to be revised a little bit to try to get more people that would benefit. So here's the quote, medium risk patients have the relatively high rate of cancer, and they can certainly tolerate evaluation. And then you've got your people that are at the highest risk because they smoked 120-pack years, but they also have bad COPD on home oxygen and have class 4 heart failure, they're not the best person for screening because they may die from their heart long before they would die from the lung cancer. So this is an evolution, but at least I just wanted you to be aware of this for your clinical judgment, and also because, as time goes on, the criteria for screening might be changed somewhat. Last slide. Sorry, my allergy is getting to me and my voice is about gone, but this is the last slide. So there is a small reimbursement for our visit. That's done by nurse practitioners and physician supervises them. And so for that visit, we get about $28, but by the time the overhead's taken out, it comes down to about $10. So this is not a way that the lung cancer screening people are getting rich by doing these trials. This is really, we have Dr. Mills here, and the reason we have this is really because Dr. Mills pushed for it, and the hospital also was very helpful because he thought this was important in our medical center to offer this. Now, radiology does a little bit better for the scans. I'm not sure how much Dr. Pavigliano gets. That's not a lot for reading the CAT scan either. But more is obtained with those people that need workups, invasive workups and surgery and that type of thing. But it's not a huge money maker here, but it's not all about the money. We're really trying to help people stop smoking and save lives, and when you consider that, there's more than just financial gain involved. So with that, I'll stop and have just a few minutes for questions if anybody has any comments. Thank you very much.
Yeah. Have you ever asked patients on a regular basis, prospective basis, particularly those patients sort of in their middle risk years, how much are they willing to purchase their cancer of the lung for?
How much are they willing to pay for it? Or?
Yeah, how much are they willing to spend of their own money to purchase the cancer that they're going to get? Because we're spending a huge amount of tax dollars to treat them.
Yeah, I haven't put it that way, but what I've come to realize is, in talking to a lot of these people, and some are more forthcoming, is a lot of our patients seem to think that if they don't have any symptoms, it's okay to keep smoking. And when they get symptoms or something's found, then they can stop and it can be dealt with. And even though we explain to them, that it's, if you wait till that point, it's often metastatic, it's not curative, they just don't seem to accept that. So I've gone over and over it, and even though it's logical to us, they just don't grasp that. They're not willing to grasp it or accept it or use it as some kind of denial that as long as they're feeling okay, I can just keep doing this. It's really not hurting me that much, and I can do it up to the point I'm sick, and then I can stop. That seems to be one of the biggest obstacles I've found. And money would help, but a lot of our patients don't have a lot of money, but they're still spending money on cigarettes, and that's because it's so extremely addictive, and that's another point. I have a lecture on smoking cessation if you want to hear that later, but it's obviously one of the most addicting substances, and money is not, prohibitive. So, and about tax dollars, I don't know that they care too much about how much you're spending on tax dollars.
That's true, but I'm trying to put the responsibility of their actions on them, not on everybody else.
Yeah.
And if they start saying, I'm not providing X, Y, and Z for my family, maybe that would.
Yeah, we could try that, but it's a tough thing, to stop smoking. And you can see that very high, in Louisiana now the smoking rate's in the low 20% range. It's definitely improved over the years, but here with our group you can see it's about 70%. Really a hardcore group of smokers that it's difficult to get them to stop.
Our state legislators don't even care. They spend the money, but Louisiana for years had the lowest tax in the country. Only Kentucky and West Virginia were lower. And it was like an act of God to get them to take us from 24 cents to $1.25 per pack on the cigarettes tax. It's still in the lower part of the nation in taxes. It certainly doesn't reimburse the state for the care that it gives. But the people just, and Jindal would support it because he doesn't want any taxes. And so even the government doesn't do this, and they're the ones putting out the money.
And the other thing is the money from the tobacco settlements in most states, I don't know every state, but much of that money has been taken for roads and other things and not for trying to get people to stop smoking or things like that. It's just a little piggy bank for them. And think of how much more. We have a tobacco counselor that comes twice a month, from the state. And we're working on trying to, with our new partner, to improve that dramatically, but that's the way it's been for years. So as far as professional counseling here, it's 2 hours a month. And that is woefully inadequate, obviously. So. All right, well, thank you very much. Okay, take care. Okay.